Hello everyone and welcome back. So we are going to discuss the topic eclampsia. So we are having a scenario that there is a G2P1 with 34 weeks of pregnancy and BP is 170 by 100. Proteinuria of +3 is present and edema feed is also present with fits. So what is the diagnosis and the maternal and fetal complications and the preventive measures for the fetal outcome? Another scenario is that there is a G2P1 24-year-old at term pregnancy who was brought to the labor room with high BP 160 by 100 and edema feet is there. So the diagnosis, the immediate steps to save her life. So what is eclampsia? It is a life-threatening condition characterized by tonic and clonic fits and loss of consciousness and frothing from nose and mouth. Now the management options are general measures which are ABC, that is keep the patient in left lateral position to prevent aspiration of secretions, then put an airway in mouth to prevent tongue bite and to keep the airway patent, suck the secretions out if present in airway, then catheterize the patient for input-output record, and large bore intravenous cannula should be seated and blood taken for FBC, coagulation profile, RFTs, LFTs, and cross-matching and fundoscopy is done. The specific measures are that stabilize the mother condition, which includes stop convulsions, that is convulsive therapy, and BP should be controlled. The management of the fluid balance and delivery of the baby is done. For convulsion, give intravenous mg/4. Initial loading dose of 4 gram followed by an infusion of 5 gram every 4 hours and maintain dose till 24 hours after the last fit. Intravenous diazepam can also be given in dose of 10 mg initially. For BP control, intravenous hydralazine or intravenous labetalol is given. For fluid balance, intravenous single lactate should be infused at a rate of no more than 80 ml per hour in absence of bleeding. CVP line should be maintained and intravenous fluid administrations must be tailored according to the CVP. Strict input-output record must be maintained and pulse oximeter must be employed. Keep a check on electrolyte, urea and creatinine, and all these precautionary measures regarding fluid balance are taken to avoid fluid overload. There is a risk of pulmonary edema and heart failure with fluid overload. Now for delivery, the timing, that is after stabilizing the patient, deliver the baby irrespective of the period of gestation, and the mode is the aim should be NVD. If she is not in labor, then induction after Bishop's score and after excluding any contraindication to the vaginal delivery. If the baby is to be delivered before 34 weeks, steroids should be given for lung maturity, and at second stage shortens with forceps or vacuum. Do not give ergometrin, that is give oxytocins, and epidural analgesia is given if she got laryngeal edema and intubation is difficult. C-section is done if baby could be delivered with C-section if fetal stress is present, that is poor Bishop's score, contracted pelvis and previous 2 C-sections. Note the C-section in eclampsia is associated with higher mortality and morbidity. Postnatally keep under strict observation for 24 hours plus continue anticonvulsants and keep a record of BP, pulse and temperature and input and output record, and same postpartum care is discussed in the preeclampsia. So we have discussed all about the eclampsia, that what is eclampsia, then how is the management done. First of all, general measures are done and then the specific measures are done. For convulsive, the specific therapy is given, BP is controlled, fluid balance is maintained, and delivery is done. The timing is after stabilizing the patient, and the mode should be NVD. Do not give ergometrin, give oxytocin. Analgesia is given. C-section can be done in the following cases as a poor Bishop's score, contracted pelvis and previous 2 C-sections. And note the C-section in eclampsia is associated with higher mortality and morbidity rate. Postnatally keep under strict observation and continue anticonvulsant therapy. Okay, now coming towards gestational diabetes. Okay, now gestational diabetes. So it is defined as fasting blood glucose level more than 7.8 millimole per liter or a level of greater than 11.1 millimole per liter 2 hours following an oral glucose load of 75 gram. Then we have the classification as gestational diabetes and type 1 diabetes, mellitus having fetal anomalies and ketosis, and type 2 diabetes mellitus in which fetal anomalies are there but there is no ketosis. If a known case of diabetes and there is less chance to conceive, and if conceived then more chance of abortion is there. In gestational diabetes, if a patient suddenly develops diabetes during pregnancy, it's known as gestational diabetes, and it complicates 1 to 2% pregnancy. Okay, so the diagnosis is done in during third trimester in during screening blood test, and the mechanism is insulin resistance. The fetal anomalies is no because this occurs later, whereas the anomalies occur during the first trimester. Now, the pathophysiology is that human placental lactogen and cortisol increases insulin resistance. The risk factors are obesity, previous traumatic delivery, age greater than 30 years, history of unexplained intrauterine death, family history of diabetes, history of prolonged labor, history of polyhydramnios, history of unexplained stillbirth, history of perinatal and neonatal death, and history of big babies that is greater than 4.5 kg. Screening is done in patients with suspicious of gestational diabetes in the last trimester, that is prenatal visit, and ideally done for all the pregnant women between the age of 24 to 48 weeks of gestation. This is when anti-insulin effect of human placental lactogen is maximum and oral glucose challenge test with no need to be in fasting state. 1 hour before 50 gram of oral glucose is given and the value is found. So the value is less than 140 mg, it is normal, and urine sugar and dipstick test and RBS are other investigations that are done. If it is greater than 140 mg per dl, then we should perform OGTT, that is fasting blood sugar, and HbA1c. If it is greater than 200 mg per dl, then it is confirmed gestational diabetes mellitus and glucose challenge test is done. Okay, for diagnosis, if abnormal screening is obtained, then we do 3-hour OGTT. It involves administration of 100 gram of glucose and it is followed by at least 8-hour fast and 4 glucose values are obtained. Now the conditions and the values are, and at normal it is less than 95 milligram per dl. At 1 hour it is 180, and at 2 hour it is less than 155, and at 3 hours it is less than 140 milligram per dl. The results: if one value is abnormal, then it is impaired glucose intolerance. If 2 or more values are abnormal, then it is gestational diabetes. If FBS is greater than 125 milligram per dl, then there is no need to OGTT. It is diabetes. Now the complications are both fetal, neonatal, maternal, and delivery complications. The fetal complications are miscarriage, macrosomia, late stillbirth, and cardinal regress syndrome, and congenital anomalies. The neonatal are hypoglycemia, hypocalcemia, hyperbilirubinemia, polycythemia, respiratory distress syndrome, birth asphyxia, birth trauma. The maternal are coronary artery diseases, retinopathy, preeclampsia, infection, thrombolytic diseases, nephropathy, increased risk of PPH, neuropathy, and perineal tears. The delivery are obstructed and prolonged, birth trauma, asphyxia, and shoulder dystocia. Okay, neural tube defect and congenital heart diseases are also the complications of fetus. Now, management. First of all, history is taken, that is, ask about any risk factor, and then ask if she is already diabetic and is on the same drugs. Then examinations are done, that is GP, check vitals, and obstetric examination is done. Then investigations are done. On admission, blood sugar is done, that is 1 fasting, and 2 random blood sugar values daily till it comes to normal. OGTT is done, urine examination is done, that is glycosuria, proteinuria, and ketonuria. Serum electrolytes are done, that is hyponatremia and hypokalemia. Fundoscopy is done to exclude the diabetic retinopathy in each trimester. RFTs are done to exclude the nephropathy and serum uric acid level and urine albumin. HbA1c is done, that is 3 months record is checked, and ECG is done for ischemic heart disease. Okay, now preconception counseling is done, that is healthy diet, weight control, avoid smoking, folic acid supplementation. Okay, folic acid supplementation to avoid neural tube defects, rubella vaccination, screening preconceptionally, and control hypertension. Now the management in antepartum management, antepartum fetal assessment, and antepartum intrapartum management. So the antepartum management is that it is divided into dietary modification, insulin therapy, and overt diabetic management. Dietary modification: calories 1800 to 2200 kilocalories per day, folic acid supplementation, and encourage the complex carbohydrates, high fiber diet, steady and gradual weight gain, and avoid concentrated sweets. Insulin therapy is given, that is monitoring the home blood glucose level at least 4 times a day with a target of FBC less than 90 and 1 hour after meal. Then insulin therapy is given, that is total daily units 2 by 3rd in the morning and 1 by 3rd in the evening. Dose calculation is then, that is trimester wise, and then the calculation. For first trimester, body weight in kg multiply by 0.8 divided by total daily units of insulin. In second trimester, body weight in kg, that is 1.0, and total daily unit of the insulin. In third trimester, body weight in kg multiply by 1.2 is equal to total daily unit of the insulin. Now for over diabetes management, HbA1c is done to check the long-term glycemic control. The renal status is checked, that is 24-hour urine collection for total protein plus creatinine clearance, and retinal status is checked, that is fundoscopy evaluation for retinopathy, and glucose monitoring is done, that is target values of FBS less than 90 and 1 hour after meal, that is less than 140 mg per dl. Now the intrapartum assessment is that neural tube defect, that is triple screen markers at 16 to 18, Down syndrome, that is nuchal translucency scanning, structural anomalies, that is targeted ultrasound at 18 to 20 weeks, congenital heart diseases, fetal microsomia, that is intrauterine growth resuscitation, monthly sonogram is done, vasculopathy, hypertension, and poor glycemic control. And intrapartum management is maintain normoglycemic conditions with insulin along with early blood glucose measurement, maintain fetal monitoring and fetal scalp blood sampling if abnormal CTG. Mode of delivery is vaginal, but C-section occurs in 50% of cases due to macrosomia babies and arrest in labor. If premature preterm, give intramuscular steroid for improvement of lung maturity, which can be confirmed by an amniotic fluid. Lecithin to sphingomyelin ratio of 2:5 and the presence of phosphatidylglycerol. Stop the administration of insulin at delivery as the insulin resistance drops with fall in level of HPL after delivery of placenta, and a full glucose tolerance test should be done after 6 weeks following delivery to ensure diabetes. So this was all about diabetes. Let's revise. Gestational diabetes. This is eclampsia, this is gestational diabetes. Okay, so we have discussed the definition, then the classification, which is gestational diabetes and type 1 diabetes mellitus and type 2 diabetes mellitus. Then we have discussed the diagnosis, the mechanism, the fetal anomalies, and the pathophysiology. Then the risk factors, the screening, and then the diagnosis, then the complications, which are fetal, neonatal, maternal, and delivery complications. Then we discuss the management, that is history, examination, investigation. And in investigation, blood sugar, urine examination, serum electrolytes, fundoscopy, RFTs, HbA1c and ECG is done. Preconception counseling is done of the patient. Management is done for antepartum management, antepartum fetal assessment, and intrapartum management. In antepartum management, dietary modifications and insulin therapy. Over diabetic management, in antepartum fetal assessment, NTDs, Down syndrome, structural anomalies, congenital heart disease, fetal macrosomia, vasculopathy, and poor glycemic control. In intrapartum management, the mode of delivery and the okay, so this was the end of the gestational diabetes. We have discussed all the topics of obstetrics. That is, this is the index. We have covered all these topics: perineal traumas or tears, perineal repair, instrumental vaginal delivery, vacuum C-section, anemia in pregnancy, folate deficiency anemia, hypertensive disorder of pregnancy, preeclampsia, eclampsia, and gestational diabetes.